Welcome. We're glad to have you with us. Today's February 18th, so this is our Trion Medical webinar, and we appreciate you taking 30 minutes, not 30 days, out of your day to join us today. You know, there's quite a bit of practical application in what you're going to hear from us, and it seems like the right time to revisit things like the quarantine guidelines, masking, what's yet to come in groups 3 and 4. In addition to that, Dr. Owen is going to highlight for us what he sees as necessary changes for us to have a successful vaccine distribution. And so I'm going to predict right up front that today's going to be a heavy question session. So go ahead and be sure to put those in the chat at any point. You can start now if you'd like. And it is true in what you're about to see, the cases are down significantly, and that's a good thing. But it's also, as Dr. Owen has cautioned us before, it's also still higher than it was back in July, which was the peak for the summer. And as I always do, I'll give you a quick public service announcement. If you want to communicate with us outside of today's webinar, go to triondirect.com. Some of you email me, and that's perfectly fine as well. So with that, Dr. Owen, I'll turn it over to you. We got the agenda slide up and we can get rolling.
Okay, so today, to try and not have a computer glitch that sends me out of orbit here, what I'm trying to, using a different system here, and so it may look like I'm looking in different places because I am getting used to a new camera and where it's situated. So let's go ahead and take the first slide. All right, pretty straightforward. We've seen this before, but it's a continuation of what we saw last week, and there's no question that the cases are decreasing, and we're still above the peak of the first wave. Remember how bad we thought that was. Only little did we know. And then you can see how in the bottom right, the hospitalizations are coming down. It's not and quite gotten to the point that the overall cases have. You see that's usually a 7 to 14 days lagging behind. And then the deaths reported are coming down from a daily basis. We're getting close to 500,000 people having passed away from COVID-19 here in the United States. Remember, in the Spanish flu, there were 675,000 deaths. And so that we're well above 70% of the deaths that we had then. The rest of the world, hate to say it, is less than 10% of the overall deaths for the rest of the world. So we may not be doing as well as we would like to be doing, but things are improving dramatically from a standpoint of the overall cases. I'm really, really hopeful that the vaccinations will help blunt this curve even more. And with that, let's go to the next slide. So I love the question last time about the quarantine guidelines, and I tried to give more of a overview rather than a real specific and succinct answer. So let's go into the actual guidelines about quarantining based on exposure, and you can see the following. If you're exposed to someone with COVID-19, vaccinated people do not have to quarantine if they meet all 3 of the following criteria. Number 1, they're fully vaccinated with at least 2 weeks since their final dose. Number 2, that they are 3 months since receiving, within 3 months since receiving their final dose. And number 3, they've remained asymptomatic. So you can get this again. Remember, these vaccines, they're effective 95% of the time at preventing COVID-19 infection, but 5% of the time they were not. But they did have 100% decrease in risk of hospitalizations and death rate associated with developing COVID-19. Number 1 and number 2 there are probably the most important. It takes you about 2 weeks to get the full effect of the immunity. from either shot, from the first dose or second dose. So the first dose gives you about 50% immunity, and that is developed within about 2 weeks. And the second vaccine gives you the rest of your immunity, and that should be mostly fully developed after 2 weeks of after the second vaccine. We believe that's also going to be the case for the Janssen trial and for the Janssen vaccine. When it has just a single vaccine, it's going to be about 2 weeks after that. But remember, this is sort of an unusual number 2 here, but you can't be beyond 3 months having received the final dose. Why do you think that is? It's pretty straightforward, because we don't have a lot of experience beyond 3 months having had the vaccine at this point. And so the trials are still about 3 months from those times. And so we will see in another month, they may be able to say it's 4 months. And in 6 more months, they may be able to say it's 9 months, because they're going to be able to look back at each of these trials and see how long these antibodies are lasting and how long these people in the trials remained asymptomatic and did not catch COVID-19. So that's going to be really important. This is also taking into account, though, that we don't have a major problem with one of the mutants, one of the mutations here in the United States. Now, we have the UK variant here. We have the South African strain here. We have probably, and don't even necessarily know it, the Brazilian strain here. But our dominant strain is still the one that came from Europe and Italy at the very beginning. It's predicted, though, that the UK variant and then maybe potentially the South African variant will become the dominant strains, because they're more contagious, and they're going to outflank that strain we had most dominant. So these guidelines are based on the dominant strain being the one that we know today. That may not be the case as we see these other strains become the more dominant strain. All right. So people who have been in close contact with someone who has COVID-19, excluding people who have had with the actual virus in the past 3 months, they have to tested positive for COVID-19 in the past 3 months and recovered. People who develop symptoms again within 3 months of the first bout may need to be tested again if there's no other obvious cause. Like you get a bad sore throat and you test positive for strep, okay, you probably have strep throat and not COVID-19. Those types of things are pretty straightforward. Let's move on to double masking. Why do we think that we're recommending double masking? Well, because we're looking for these mutant strains that are more contagious. We want to block their spread. It's pure and simple, mostly from that standpoint. In lab tests, about 95% of the potentially infectious aerosols are decreased when they wore both tight-fitting masks, and they give you different options. Usually you wear a surgical mask underneath a cloth or nylon mask. That's what's recommended. Next slide. All right, so North Carolina now has given its first dose to almost 12% of the population, and its second dose to almost 5% of the population. And about a month and a half ago, we were pretty woeful and in the lowest 10% of the states in the nation. And we're right now in the middle of what we're generally seeing. Most of the US population, at least one shot is 12%. We're 11.7%. We're just below. That means we're right in that middle of the road standpoint. 2 shots, 4.7. We're ahead of that at 4.9%. Doses used. 78% of the dosages have been used. And why do we think that is? Well, some of that is because we're holding doses for a second dose for some folks. Some of that may be an overlap of some of the doses have not yet been delivered yet, because we're trying to push doses and we're being asked to reserve doses for underrepresented populations in the community. And pure and simple, that's why some of these doses have not been administered to date. Next slide.
Dr. Owen, Tom has chimed in with a question. He says, where can one get a PDF or a clear copy of the mask slide? We will get that out to everybody. We can do that. Tom, I'm with you. I have trouble. I need more glasses here, I think, to see this.
All right, well, you know, about 3 years ago, I didn't wear glasses, but reading all those cardiology studies put me in the glasses group finally. Didn't know what I had been missing. So new reported doses administered by day. Some days are obviously larger than others, but on average, 1.64 million per day. That's 1/3%, or excuse me, 0.5%. That's not fast enough. It's not even close to being fast enough. As a matter of fact, I'll say it's woeful. And look at this. Last week, I believe, correct me if I'm wrong, Kendall, the last week's slide said at current pace, 70% of first dose was September 5th, I believe. And I believe it says September 13th now. So go back and look at that and see if that's the case, or if my memory's wrong. But regardless, September anything is ridiculously too long, and it's giving way too much time for the mutant strains to develop. And you know, that's going to be part of the issue, right? And it's also, I mean, look what we need, that type of level of dosing already done by mid-March because of what's going to happen then, spring break, and then the first week of April, Easter. And we're going to have all this congregation again. And what's also supposed to happen at that time? The third wave. And hopefully that third wave will be blunted, and hopefully we'll see all these things blunted significantly by just the amount of vaccination that we've delivered by then. But I mean, we won't even have a quarter of the population vaccinated by that time. Let's go to the next slide. I'll come back to what I think recommendations should be in just a minute. So look at this, projected daily pace of vaccine shot delivery in the United States. Right now we're at 1.1 to 1.6 million. Late February and March, 3 million. Well, even at 3 million a day, that takes you 100 days to be able to take care of over 300 million people. 3.8 million, 4 million. We are supposed to have almost 600 million doses available by the end of May, 1st of June. So why in the blue blazes is it taking us so long to get these vaccines into people's arms? It's pretty simple. We don't have enough distribution sites. And when we talk about phase 3 and 4, and phase 3 is coming now, and 4 is 60% of the population, we're going to get overwhelmed with the inability to deliver this vaccine. We'll have, right now we have a problem, supply and demand. It's the supply that's not available, right? But we're going to have supply and not be able to meet the demand later. That's going to be the next problem. And I'll talk to you about that in just a minute. Let's go to the next slide. All right. So is this our last slide, Patrick? I mean, it's not? Okay, good, because I know I've seen these, and this is what I asked to be put in there today. So here's my recommendation for vaccine distribution. Number one, we need 10 times the amount of distributors to achieve herd immunity the fastest. If you go to the third point, it basically requires many more distribution sites, and we got to do it now. One of the things that we've seen across the entire nation, it's being commented on in the New England Journal of Medicine, New York Times, everywhere, the Wall Street Journal, on all the op-ed pages, is that physician practices have not been allowed to vaccinate people at this point. And the question is, why not? Do you normally go to the hospital to get your vaccine? No. I don't know anybody who does that. I mean, we get them primarily at our doctor's offices and at pharmacies, period. And that's really who should have been handling a lot of this from the beginning. I grant the fact that a lot of places did not have the refrigeration and freezers and capacity and so forth, but we do. We have a freezer that can hold 250,000 doses of Pfizer. Why weren't we given, vaccine? It's all very much bureaucratic, but hopefully we'll get our act together here soon. Point number 2, all doses given to the state should be in the arms within 24 hours, not 5 to 7 days. That will beat down the community viral load the fastest. So if you have 120,000 doses that hit the state, you need enough distributors to be able to put all 120,000 doses in the next day. We shouldn't be waiting 5 days, 7 days, and so forth to finally get them all done. So it requires many more distribution sites to do that. Phase 4 is 60% of the population. Improved vaccine supply in March through May will overwhelm the current distribution capability. And we'll be having, lots of people, lots of different groups realizing this, and that'll be too late. We've got to be proactive, not react to the problem once we stumble upon it and hit that wall. Our current rate extrapolates to 70% receiving first dose by 9/5 and now 9/13 of 21. It's way too late. It's abominable, quite frankly, for the United States, the richest country in the entire world, not to be able to get this done a lot faster. It's way too late to prevent the pressure of developing the resistant mutant strains, putting us back to square one. Because remember, the antibodies that we make have been to 2 things: either catching COVID-19 or a vaccine against COVID-19. Those antibodies are all identical because the spike protein that's being created by COVID-19, the current COVID-19 that's dominant, as well as the spike protein that's made on our own cells by the vaccine, it's the same spike protein. Therefore, it's the same antibody being made. And if we get a new dominant strain with a mutant strain that has a mutated spike protein, that it could easily make our vaccinations less effective or even completely ineffective. And that's starting over. And that's like going back to phase 1 and going through this whole thing all over again. And that's why Moderna and Pfizer are working feverishly to find these new strains and get them into a new vaccine that may be potentially for next year or even this fall. Don't be surprised if you hear that. The other thing which has surprised me the most in this need for getting distribution of vaccine out there is that nobody's doing 24/7 vaccination. Why not? The virus does not sleep. But however, it's also the time it doesn't spread as much as when we are asleep, right? Because we're static, we're not moving, we're not spreading air to a bunch of other people. But my goodness, what a great way to actually get ahead of this virus is to attack it when it's basically asleep, right? I know it doesn't sleep really, but we're not as active then, so we're not spreading as much. We actually can make ground up if we have 24/7 vaccine sites. I know nobody wants to be up till 3 in the morning. I never did when I was in residency and cardiology fellowship and all those types of things. But one time, that sure makes a big difference, I think, in being able to get these things done a lot faster. Next slide. All right, so here are the phases. Remember phase 1A? I still have patients in phase 1A who cannot get a vaccine before April. Remember phase 1B? I still have people who are in line. I have 75-year-olds in line in April and can't get any earlier than that. Phase 2, you see here what we're going through: essential workers not yet vaccinated. That's in group 4 of phase 2. We'll go to a page here in just a second about who are the essential workers and all the different groups. My wife was telling me that in real estate, she's now pulled ahead of phase 4, so she's feeling good about things, being able to get one earlier. I will say that I know some more people that I mentioned last week who stayed at some of these mass vaccination sites. And sure enough, at the very end, most of the people left thinking there weren't going to be any extras, and there were about 15, and 15 people got vaccinated. And a lot of them were, again, my daughter's friends in their early 20s. They fit phase 4, but here they are getting vaccine. They fit phase 3, actually, some of them college students still. I've even got some of my 70-plus-year-old patients, 75-plus-year-old patients who are waiting in line now, trying to get ahead of their April timeframe, their schedule they've been given. Phase 3 is right on the cusp. We're about ready to vaccinate students. That's going to be a huge deal on a lot of fronts, and especially the economic front, because it's going to allow students to get back in the classrooms, and our dual income families being able to be more productive. And I'm hoping we see a huge pop in the economy as a result of it. Whether or not we change virtual habits or not, it's going to be very interesting. The pressure was for a tremendous amount of virtual. Now, with people being cooped up for a year, I suspect there's going to be a lot of social pressure to be back at work. We'll have to wait and see. You know, employers are going to dictate a lot of this. Their employees are going to dictate a lot of it with their wants and recommendations too. It'll be very interesting to see how it plays out. And I suspect different types of employers and what they do, they'll have different types of plans. And then number 4, phase 4, is about 60% of the general population. All right, next slide. All right, here are your frontline essential workers. All right, so you've got about 30 seconds to memorize all of that. And basically, I mean, meat packing, public transit, grocery stores, college, university instructors, manufacturing workers, agricultural supply chains, food chains, clergy, vets, elected officials, post office workers. I would have put them earlier because of their direct contact with the public. And then public health workers, social workers, highway infrastructure workers, restaurant workers. Here, that's a huge one, isn't it? So education, child care staff, K through 12 teachers and support staff, all those people. And it's a huge, huge group. And we look forward to getting these folks. I mean, this is a lot of the meat and potatoes of what goes on in the country. And one could argue that perhaps this was the group that needed to be done first. I could probably make an even better argument that it's anybody between the ages of 20 and 40, because they tend to be the highest spreaders. But we did make a prioritization to vaccinate our most vulnerable first. And, you know, who can quip about that? I mean, that's certainly a very altruistic thing to do. And for a lot of right reasons. Was it the most efficient way to beat this virus down? It's hard to say. We'll probably never know. Hopefully we never have to do it again so that we do find out. Is there another slide?
I think that might be it. And I was going to, Dr. Owen will give us some thoughts to wrap up. I was going to ask Kendall, who helps drive all this, if she could comment. I'm guessing, like that last slide, Tom asked about the vaccine distribution. we will get this out to you all. Kendall, what is the best way to make sure? Because I don't think we have emails for everybody. What's the best way to make sure everybody can get these slides? Website?
Yeah, I think the best thing would be to post it on our website where we post the recordings. So you can go to tryanddirect.com and access the resources there.
Okay.
I like the two chat questions I see from
Yeah.
what can we regular people do to help get the number of distribution sites ramped up? Write your congressman, write the DHHS, call WBTV or any other media source and just complain like crazy because it's going to take a level of inertia to get the bureaucracy to change its ways. Number two, do we know how are vaccine sites validating that people fit into these essential groups? Should employers equip employees with layers to take with them? Absolutely, yes. If you'll see a very wide spectrum of how different vaccine distribution sites are going to handle things. Some of them are going to take them at their word, and some of them are not. And even within each site, some of the people giving a vaccine will and some others won't. So if you can help them out, I mean, the last thing we want to see are people standing in line and waiting, getting their vaccine schedule and such, and then be sent home because they don't fit this very specific criteria. Use a broad stroke in your letter. Pick out one of the things that you know that they do that crosses over with one of these essential workers and so forth. Paint a broad stroke. If they have a very specific thing that is stated, use that. But anything you can give them that arms them, gives them the ammunition when they show up and they can present something, sure, it helps. It will never hurt.
Anybody have any other questions? We got about 2 minutes. Dr. Owen can wrap us up. If not, go ahead and type in the chat if you do. We'll squeeze it in.
All right, wrapping up, don't let your guard down. Even though you've gotten a vaccine or you've had two, don't let this get out of control. Don't be one of the 5% that gets sick and is still out there spreading it. We don't need that. And we need to get the distribution sites ramped up really, really rapidly because we really specifically need to beat down this total viral load that puts pressure on making new mutations that may make these vaccines and our previous immunity, even to previous COVID infections, ineffective. Huge, huge issue. Had a lady today in my practice say, I've gotten both vaccines and tomorrow will be 2 weeks after and all my bridge partners have the very same thing. Can we all play bridge together again? I said, you can play bridge together as long as each of you are willing to certify that you're maintaining appropriate social distancing and wearing a face mask in public and all of the people living in your house are doing the same and so forth. So remember, it's still a melting pot. Be careful. There'll probably be more liberties gradually that people will take. It will, as a result, create more infections, but hopefully not nearly at the rate that we saw previously. It says, I have seen where essential frontline refers to only those that have to be on site, not those working from home. Is that correct? I don't know the answer to that specifically. How would they know? Nobody has to say that they're working from home. You know, this is my job. This is what I do. You know, you might be working from home now, but you didn't then, you didn't previously. So your typical job, my job description is I'm at work doing the following thing. Okay, yes, right now I'm at home. They don't need to say those things. Don't go volunteering those things. Don't volunteer anything that makes it less likely that they get a vaccine.
All right. I think that's a wrap. No more questions. So we'll go ahead and part here. And as always, we really appreciate you taking the time with us. We wish you a great rest of your day and a great weekend, and we'll be back with you next week.
Thank you all very much. Have a great week.